We'll be talking about preparation for radiological investigations today. And the radiological investigations can be categorized as the diagnostic modalities, the X-rays, conventional contrast studies, mammography, ultrasound, CT, and MRI, and we'll be talking about the preparation for these today. Whereas the interventional procedures and the DSA will be covered in a separate talk. So how do we address the diagnostic modalities? Now, coordination and communication between the referring physician and the radiology department is essential to obtain meaningful and relevant information about the disease. So, be it an urgent investigation or an elective one, I think there are 4 queries, or we can organize the entire process into 4 questions. That is, what the referring clinician needs to consider, what the patient needs to be informed about it, what the radiology reception needs to cross-check while scheduling elective scans, and what the radiologist or the technician needs to check on the day of the scan. So let us just consider each of these points one by one. So what the referring clinician needs to consider. So let us talk about the elective investigations, because in the urgent ones, there is a direct communication between the clinician as well as the radiologist, and the investigation is frequently done, even if the preparation is not done or is suboptimal, because it has some immediate impact on the patient management. So we'll be discussing about the elective investigations. We need to choose the correct investigation. What do I mean by the correct investigation? Now, there is a whole myriad of options available. So even if you consider maybe a CT of the chest, now there could be an HRCT, there could be a contrast enhanced CT, or there could be a CT angio. So based on the clinical details or based on the clinical query, the correct form needs to be raised. If you are seeking information about a lung pathology or an ILD, the HRCT is what you need to be taking on. If there is a mediastinal mass, or if there is a mass that you're looking for, then a contrast enhanced CT would do. But if the suspicion is of pulmonary thromboembolism, then a CT angio is to be raised. And you also need to specify that you are looking for specifically pulmonary thromboembolism. Just simply writing CT angio may not also be adequate, because CT angio, you might be asking for a patient with hemoptysis who might be, for whom you might be interested to look for the bronchial artery. Whereas if the patient has DVT and you're wanting to rule out pulmonary thromboembolism in the pulmonary artery, so the phase of the scan, that is a CT protocol, the delay of the contrast administration and the volume of contrast will also change. So all of these things have to be taken into account while raising the investigation. Then you also need to assess the feasibility. Can the patient cooperate? And we are talking about specific situations where the patient may be very agitated, or the patient may be in altered sensorium, where an MRI may not be feasible, whereas a contrast enhanced CT might be feasible because it takes a lesser amount of time. So all of these things have to be taken into account. And then, are there any specific contraindications? Now, that applies mostly to MRI, because if there is a patient with a cardiac pacemaker or an MRI incompatible device, then one might have to think of alternative investigations. Then, is contrast needed? Because if it is, if you're thinking that the patient needs a contrast enhanced study, it is wise to get a serum creatinine form raised at the same time, so that there is no further delay in scheduling the scan. Any comorbidities, it is good to mention these, because that might affect the way the scan is scheduled, or the way the protocol is used. For instance, in a patient who has diabetes, we would like to give the morning slot to that patient. If the patient has any other morbidity which might affect the contrast being given or not, these need to be specifically mentioned on the form. For female patients, you need to check about the pregnancy status. Now, why I'm writing it here at the level of the referring clinician is because sometimes the patient is not scheduled for a scan on the same day or the next week. Sometimes in OPD patients, what you would say is you come after 3 months and in follow-up, and you get your CT done. So the patient needs to be informed that at that time, when the patient's CT is scheduled, at that time she should be careful and not have a pregnancy at that time. So this is something which you need to preempt and inform in advance. Now we've already talked a little bit about adequate clinical details. So just to give you some further examples, how a specific query will give you a specific answer. For instance, there may be a patient with pancreatitis. You already know that the patient has pancreatitis. So you are not actually looking for the diagnosis. You might be looking for the extent of the pancreatitis, or you may want to be ruling out a pseudoaneurysm. Sometimes disruption of the pancreatic duct is what you might be looking for. So unless and until you give the specific query, you're very unlikely to get specific answers. So that's an important thing. Sometimes a patient with subacute intestinal obstruction, and there may be very subtle findings, or there may not be very obvious things visible on the CT scan. However, if there is a history of prior surgery, then it may be due to adhesions, and even a subtle abnormality. The radiologist may like to go ahead and do some delayed scan or take extra thin sections. So these are the kind of things, if the clinical details are available at the time of the scan, then it is better, then the scan may be performed better or tailored more towards the specific clinical information which is being sought. Sometimes you may want to know the status of the lymph node. So instead of presuming that the radiologist is going to be able to give you all the answers, it is better to spell it out so that the examination is tailored better. Then you need to inform the patient or the relative about what investigation is being asked for, because if they're prepared, they might be able to cooperate better. In some situations, you already know that the patient has raised creatinine, but you still would like to know you would still like to go ahead with the investigation. And in these situations, it is better to prime the patient beforehand and consider high-risk consent, so that an alternative can be thought about. At the same time, it can be discussed with the patient, and this would avoid further delays in scheduling any scan. So part of it has already been covered. What the patient needs to be informed is about the investigation, specific preparation which he needs to do or to come fasting. It's nice to know how long it will take, because sometimes the patients may have to take some leave or come. So if they know that they might need to spend more time, it would be better. What instructions will be given during the test? So it's nice for the patient to know that they might need to hold breath or lie still. So all these things are important to counsel the patient to decrease their anxiety. It's important to inform if radiation is involved or contrast is needed. It's also important for the patient to know whether he can take his routine medications or to stop certain medications, and what about insulin injections. So these are queries which come to the patient's mind, and these need to be sorted. We need to inform them whether they need to be nil orally, or they can take their morning tea or liquid or juices. So all of these things the patient would like to be informed about. So now that we've got the form in place, the patient is informed, and the patient is finally sent to the reception for scheduling. Of course, these are the first 4 points that I have written in each slide, is just to highlight the importance of cross-checking these at multiple points, in multiple times. In pediatric cases, it is important to explain about the need of pre-anesthetic checkup and anesthesia protocol. And this needs to be told to the patient in advance so that they can prepare accordingly. They need to prepare their stay accordingly. And they need to also be told where exactly they have to go to get the pre-anesthetic checkup done. And special consideration for cancer patients, which we treat on priority. We like to schedule these also on priority. A list of instructions and consumables to be given to the patient is given by the radiology reception with explanation of the same. Sometimes just handing over the list to the patient is not of much help, because they need to be told exactly what is to be done, where they have to go and get the medications, and where they have to report for the CT or the MRI or the ultrasound for that matter. They need to be to bring an attendant if they have any prior imaging, old reports. All these have to be told for them to bring. And also coagulation profile in case a biopsy is planned. So all of these things have to be taken in account when we are preparing a patient for any investigation. So now on the day of the scan, the radiologist and technician will do a final cross-check of the same four questions, that is the clinical query. Can the patient cooperate? Are there any comorbidities? Are there any contraindications? For female patients, a last cross-check about the pregnancy status. If the contrast is to be done, it's creatinine. Now, all of these, then you need to cross-check that whether the patient has complied and taken the pre-procedure preparation which was asked for, especially fasting and fluid intake. In case the creatinine is raised, we need to discuss with the clinician, obtain high-risk consent if contrast is deemed necessary. Now, at this point, it is important to specifically ask for any history of prior contrast reaction. So, we would be discussing this in a subsequent slides as well, but we need to know whether if there was a mild or moderate reaction, and whether pre-medication is needed or not. For patients who've had severe contrast reaction in the past, it is better to avoid contrast again and think of alternative investigations. If there are any prior imaging available for comparison, it is good practice to take it at the time of the scan and give a comparative report rather than calling in the patient in a next session with the prior ones. And it is important to cross-check that whether informed consent was taken or not. So specifically for X-rays and conventional procedures, what we need to be talking about is any recent investigation, whether there was any barium study done in the recent past which might give artifacts. Check if the patient has any hearing problems. Now, this is very important because sometimes the instructions may be given and the patient seems to be cooperative, but since he can't hear, he doesn't follow the instructions. So that is important for the technician to ask and cross-check whether he can hear what is being told to him from the console, because the patient is in the system, whereas the technician is outside at the console. For contrast studies, it is important to ensure that the relative accompanies the patient. Now, this is at the time of giving instructions to the patient that he needs to come with an attendant, otherwise it is difficult to get a contrast study done. Patient preparation, going on to specific conventional studies of fluoroscopic exams, there is no special preparation for routine X-rays except for LS spine and abdomen. For GI studies such as barium swallow, upper GI studies, barium enemas, a fasting of 8 hours is needed. For feeding tube checks or to verify placement, nephrostogram, no fasting is required. For enemas and IVP patients, a colon cleansing preparation is given, and those instructions are given at the time of scheduling. And we also need to inform the patient about side effects such as bloating and diarrhea. For a CT scan, what we need to do is ask the patient to remove any jewelry or any metallic objects that might interfere with the scan, instruct about the need for lying still and for breath hold, and to close the eyes when the laser light is switched on. In case contrast is to be given, it is good practice to inform the patient beforehand that he might feel warm, because this would avoid him getting shocked and moving inadvertently. So this is important. The nursing staff need to be informed about the preparation, the gauge of the IV cannula, and any limb to be spared in cases of fistula or AVM, or if there is a lesion expected in the right arm, we would like to give the IV contrast from the left side, or in cases that the serum creatinine is borderline, we would like to hydrate the patient. And if oral or contrast is to be given, it needs to be specified whether we need oral positive or negative contrast. So generally, we like to give oral negative contrast. Oral positive contrast is indicated in specific clinical situations in the post-operative period when the clinician would like to rule out any leak. So these are important points which need to be taken into account when we are preparing a patient for CT scan. In special occasions when CT angiography is planned, we need to tell the patient that he would be asked to drink plenty of oral fluids. For enteroclysis, the patient would be sent for NJ tube placement, that is a new nasojejunal tube placement first. So the patient needs to be told about it, and coordination between the two areas has to be done. For CT cysternography, lumbar puncture would be done. For CTU, the patient needs to wait for a delayed scan. The patient needs to be told about it. And for suspected rectal lesions, an enema would be given. So these are the special cases where different preparation would be needed. For contrast studies, the patient needs to actually be screened for the following 3 points which we've talked about earlier. Prior adverse reactions, any history of diabetes or kidney disease. These are not absolute contraindications, but these are comorbidities which we need to be taken into account. And we would like to give the smallest amount of contrast possible. We would like to give lower, smaller, or the safer contrast media in these cases. For patients on chemotherapy, it is preferable to secure an IV cannula from the ward, because sometimes these patients, it is difficult to put in an IV cannula, and if the patient is already admitted in the ward, it is better that the patient comes with a patent IV line. Then we need to have a special mention about serum creatinine. Of course, if it is normal, there is no problem. If the serum creatinine is borderline raised and the scan is elective, we need to consider the possibility of hydrating the patient well before and doing the procedure and after also. If the serum creatinine is raised and yet investigation is deemed essential, discuss with the clinician and the patient and consider a high risk consent, and discuss about the possible need of post-procedure dialysis at the same time. So this is a high risk informed consent for the patient. So the guidelines which have been revised recently say that if the EGFR, so instead of relying only on the serum creatinine, the EGFR is taken into account. And if the EGFR is more than 30 ml, there is a low risk of acute kidney injury. If GFR is less than 30 ml, there is a high risk of AKI, and we would like to avoid iodinated contrast. If it is essential, we need to hydrate the patient well. So for hydration, we ask the patient to drink 500 ml of water for 2 hours before the examination, and another 500 ml after the procedure. If the patient cannot drink orally, IV hydration with 0.9% normal saline, 100 ml per hour for 6 to 12 hours before the exam and also after the exam. This is, of course, if the patient is not on fluid restriction. So all of these things have to be taken into account. Now, just a few concerns about contrast use. Should skin testing be done? Because of its low sensitivity, immunological skin testing cannot be used as a reliable screening tool. Then what about seafood allergies? They do not need pre-medication. Patients with asthma also do not need pre-medication. Patients with previous mild allergic reactions have less than 1% chance of developing a moderate to severe reaction, which is true. In patients with a history of moderate contrast reaction, pre-medication with corticosteroids and antihistamine regimen should be strongly considered. So just to define what the current guidelines say, the AKI or the acute kidney injury is defined as an increase in serum creatinine by 0.3 milligram per DL within 48 hours, or a more than 1.5-fold increase in serum creatinine, or oliguria less than 0.5 ml per kg per hour for 6 hours. So this is how AKI is defined. And it remains unclear whether patients with an eGFR of less than 30 are at an increased risk of developing post-contrast AKI. But based on recent studies, the incidence of AKI is lower than was previously understood. Of course, peri-exposure volume expansion can reduce the rates of post-contrast acute kidney injury. So the pre-medications which we could use prior to the administration of contrast, this is prednisone 50 milligram per orally at 13 hours, 7 hours, and 1 hour prior to administration of IV contrast, or methylprednisolone based pre-medication 32 milligram methylprednisolone by mouth 12 hours and 2 hours before contrast, and diphenhydramine 50 milligram per orally IV or IM 1 hour prior to the planned administration of contrast. And in special cases, that is metformin, this needs to be discussed with the clinician. And since metformin is primarily excreted by the kidney, there is a theoretical risk that PC-AKI may precipitate lactic acidosis. So these are special in situations where a discussion with the clinician is necessary. Then other special consideration regarding the use of contrast is in hyperthyroidism, in the history of unrelated allergies, anxiety, cardiac disease. These are not absolute contraindications, but these require caution and a discussion with the clinician. Coming on to ultrasound or guided FNAC, very simple preparation for abdominal ultrasound, gallbladder, renal artery ultrasound. The patient should be fasting for at least 6 hours prior to the exam. For KUB or pelvic examinations, the bladder should be full, so the patient should be asked to drink fluids prior to the examination. Breath hold practice needs to be instructed for the patients coming in for renal Doppler. For guided FNAC or biopsy, check for the coagulation profile, explain the procedure, take consent, and also explain about the sample transport to the pathology department. That's an important step because sometimes the samples might get lost in transit. So it's important for the patient to know that the guided FNACs will have to be followed with the reports coming in from the pathology department, and they need to take the samples there. So preparing for an MRI. Now, patient screening prior to an MRI, there are a very small number of absolute contraindications. So the absolute contraindications are ocular metallic foreign bodies or mobile foreign bodies. For this, if there is any doubt, an X-ray PNS Waters view may be done, or sometimes a CT orbit might be done. We need to remove all metallic objects, including jewelry and drug delivery patches. And if the patient is scheduled for an MRI of the abdomen or an MRCP, then it is good practice to discontinue iron tablets for at least 3 days prior to the examination, because these cause a lot of artifacts. Acoustic noise protection, earplugs or pads or headphones may be given to the patient before the examination to reduce discomfort. Now coming on to the basic terminology with regard to MRI implants and devices. The safety terms have been recently revised in 2005, and we have 3 different categories now. MRI safe or MRI conditional. In these, the devices demonstrate no known hazards to specific MR environments with specific conditions of use. So there are certain devices which can be taken into MRI for specific duration of time and in the specific environment, such as a 1.5 Tesla or a 3 Tesla. So we need to know which of these devices are MRI unsafe or conditional. And there is a resource, the mrsafety.com, in which you can get all the relevant and reliable information about the MRI compatibility of most devices and implants. So it is important to cross-check before putting the patient in for an MRI in cases where MRI conditional implants have been. So for this, even there are certain pacemakers which are now MRI conditional, but these require a specific relevant technician to put them in that mode. So there are entry and exit protocols for these MRI conditional devices, and the program can be changed. So the patient needs to be told that these devices have to be, the settings have to be altered before and after scan, and the emergency team needs to be ready during the scan. So cochlear implants or ear implants are absolute contraindications. Drug infusion pumps, insulin delivery systems, these are all contraindications. And the relative contraindications are coronary or peripheral artery stents, programmable shunts, airway stents, and tracheostomy. So if it is plastic, we can continue with the MRI. If it is unknown or unsafe, then we need to change to a plastic tracheostomy before taking the patient in. IUDs, again, if there is, if the data about it is unknown, then unknown IUDs, the MRI can be done in a 1.5 Tesla machine, but it is not safe in a 3 Tesla system. And for ocular prosthesis also, it is a relative contraindication. For tattoos, it is important to know about these. If it is in the area of interest and is less than 6 weeks old, then we need to reschedule the scan. If it is touching the bore of the scanner or the MRI coil, it may heat up. So we need to use ice packs or padding against the tattoo. For colonoscopy in the last 8 weeks, any endoscopic clips or pill can be placed. So these are relative contraindications. Some MRI sequences which require breath hold or cardiac MRI, if the patient is not cooperative, then it is not possible to do an MRI for that patient. Patients with a high body mass index that are overweight may not be able to fit into a narrow bore of the MRI machine. And of course, claustrophobic patients would not be able to get a scan done unless they are sedated properly. Now, there may be some MRI compatible devices which would cause artifacts severe enough to degrade the image quality. So it's important to realize that suppose there is some device which is, say we are looking for MRI of the head and the patient has a hip replacement. So that is not going to make a difference to the scan and we can go ahead. However, if we want to do MRI of the pelvis in a patient who's got hip prosthesis or the total hip replacement done, then the quality of the image would be degraded so much that a scan of the pelvis would not give any relevant information. So we've already talked about the conditional MR compatible devices. We need to know that not all companies offer the option of unlimited scanning without inclusion of the thorax. Some companies allow only a 30-minute MR scanning and only in afebrile patients. And despite having MRI conditional pacemakers, some companies do not have MRI conditional defibrillators and CRT systems. So these are things which we need to consider when we are planning MRI for such patients. And moving on to the serum creatinine in patients who require gadolinium. So serum creatinine, the eGFR calculation should be done if there are risk factors such as age above 60 years, history of kidney disease, a family history of kidney failure, diabetes, hypertension, multiple myeloma, solid organ transplant, and history of severe liver disease. So in these patients, we need to be careful about the eGFR calculation. And if the eGFR is below 30 ml, there is a risk of NSF. NSF is basically a multi-system disease with fibrotic changes affecting the skin, lungs, heart, liver, and muscles. The incidence is less than 5%, and it is even lesser now with the macrocyclic agents. However, what we are using here are the linear, non-ionic linear gadolinium contrast, Omniscan, and Magnifist. So we still have a risk of causing NSF to these patients. In some other countries, the linear compounds have been discontinued, but in India, we still are using these ones. A past history of allergic or anaphylactic reaction to gadolinium is a contraindication to the use of gadolinium. Subsequently, in pregnancy, it is not safe to give gadolinium. So it is a contraindication to gadolinium. However, risk-benefit assessment would be needed if it is deemed absolutely essential. And according to the European Society of Urogenital Radiology, hemodialysis shortly after gadolinium contrast does not prevent NSF, but dialysis after the MRI can reduce the gadolinium contrast load. So this is what we need to keep in mind. And moving on to the frequently asked questions. So now that we know about the preparation, there are some queries which come into mind. If serum creatinine is borderline, which CT contrast to use? So there is no conclusive evidence to suggest that iso-osmolar contrast, that is Visipaque, is less nephrotoxic than low osmolar contrast, that is Omnipaque, which we use. However, Visipaque may be preferred if there is volume overload or the patient is on dialysis. If the creatinine is raised, should we prefer CT or MRI? So that depends on the tissue or the region being investigated. If contrast must be given, then CT as an iodine-based contrast agent are easily dialyzed. So that is on a case-to-case basis to decide which is better. Considering the role of N-acetylcysteine, is there a role or not? So as of the present guidelines by the ACR, that is the American College of Radiology, the role is still uncertain. But when NAC is to be used, the original dose should be used, that is 600 milligram twice daily on the day before and the day of exposure to contrast. Then the other thing is, how do we calculate EGFR? There are certain formulae available online, and there are two formulae which are in common use, the MDRD and the Cograft GALT. And the MDRD is the one which is considered better, and that is what is being used. If the patient is scheduled for dialysis after investigation, should we prefer a CT or MR? We've already talked about this. As gadolinium is not easily dialyzed, it is better to do iodine-based contrast because it can be filtered by dialysis. Now, if the patient has a metal implant, how early can an MRI be done? So, if the patient had a knee surgery done so we would actually like to do an MRI or any scan after 6 weeks. We would not like to do it within that period. Of course, again, this is a case-to-case basis. If there is an urgent need, then it might be considered earlier also. So the take-home message is for preparation of the patient, we need to choose the correct investigation. We need to assess whether any contraindications, absolute or relative. We need to provide the relevant clinical details, and we need to also know what information is expected from the test. So that is a specific query to obtain a specific answer, and also to assess whether the patient can cooperate, and if not, to make proper arrangements so that the scan can be smoothly conducted and relevant information is obtained. Thank you for your attention.